Welcome to Section 5. In this section, we will see the methods for detection of antibiotic resistance with special focus on disk diffusion antibiotic sensitivity testing method. This slide lists 6 methods for detection of antibiotic resistance. In this section, we highlight 3 methods: disk diffusion, broth or agar dilution, molecular testing. We will start with describing the disk diffusion AST method. The disk diffusion method is the most common AST method because the handling of the test is simple, straightforward, and does not require any special equipment. In the disk diffusion method, a growth medium, usually Mueller-Hinton agar, is first evenly seeded throughout the plate with the isolate of interest. Commercially prepared antibiotic discs are then evenly dispensed and lightly pressed onto the agar surface and incubated for 18 hours and sometimes longer. The zone around an antibiotic disc is measured in millimeter and compared to a standard interpretation chart used to categorize the isolate as susceptible S, intermediately susceptible I, or resistant R. This slide shows AST results after 24 hours incubation. This is the zone of inhibition. This is bacterial growth. This is an antibiotic disc. The different discs show differing zones of inhibition, which should be measured to determine if they are susceptible, intermediate, or resistant, as shown on the next slide. For example, this isolate on the left has a zone of inhibition of 10.1 millimeters around the antibiotic disc, ampicillin. If the zone diameter interpretation chart is as follows: resistant 13 millimeters or less, intermediate 14 to 16 millimeters, susceptible 17 millimeters or more. This particular isolate is read as resistant to antibiotic ampicillin. Minimal inhibitory concentration is the lowest concentration of an antimicrobial agent that prevents visible growth of a microorganism in an agar or broth dilution susceptibility test. It is often expressed in micrograms per milliliter or milligrams per liter. MIC is determined by preparing solutions of the chemical in vitro at increasing concentrations, incubating the solutions with separate batches of cultured bacteria, and measuring the results using agar dilution or broth microdilution. Results are graded into susceptible, intermediate, or resistant. MIC may be determined using broth or agar dilution methods. In this picture, broth dilution tube method is shown. Tube 4 shows the minimum inhibitory concentration. This should be converted to micrograms per milliliter or milligrams per liter. In this picture, broth dilution microtiter plate minimum inhibitory concentration method is shown. This plate shows testing of minimum inhibitory concentration for 2 organisms, E. coli, rows A to D, and Staph aureus, rows E to H. The minimum inhibitory concentrations are identified with the blue arrows. Determining whether the organism is susceptible, intermediate, or resistant is done by reference to the cutoff values in CLSI or EU CAST guidelines. This method can be easily automated. AST by MIC will be described in detail later. According to the CLSI, the susceptible category implies that isolates are inhibited by the antimicrobial agent when the recommended dose is used. Note that this definition says nothing about the chances of clinical success. In fact, predicting clinical outcome based on susceptibility testing and the use of drugs shown to be in the susceptible category is very imprecise. This is due to a range of factors such as the effect of host responses, site of infection, toxin production by bacteria that is independent of antimicrobial susceptibility, the presence of biofilm, drug pharmacodynamics, and other factors. According to the CLSI, the intermediate category includes isolates with antimicrobial MICs that approach usually attainable blood and tissue levels, and for which response rates may be lower than for susceptible isolates. The intermediate category implies clinical efficacy in body sites where the drugs are physiologically concentrated, for example, quinolones and beta lactams in urine, or when a higher than normal dosage of a drug can be used, for example, beta lactams. This category also includes a buffer zone, which should prevent small, uncontrolled technical factors from causing major discrepancies in interpretations, especially for drugs with narrow therapeutic margins. According to the CLSI, the resistant category implies that isolates are not inhibited by the usually achievable concentrations of the agent with normal dosage schedules and/or that demonstrate zone diameters that fall in the range where specific microbial resistance mechanisms, for example, beta lactamases, are likely, and clinical efficacy of the agent against the isolate has not been reliably shown in treatment studies. Note that this definition also says nothing about the chances of clinical success, and there are high chances of imprecision. This is due to a range of factors mentioned in the case of susceptible ones. With the exception of urinary bladder infections and some mycobacterial infections, most clinicians avoid the use of a resistant category drug to treat infection. As mentioned before, laboratories should use standards for reporting quantitative resistance data, example, minimal inhibitory concentrations or zone diameters that will detect decreased susceptibility. This is necessary because numerical antimicrobial test results reported qualitatively, for instance, as susceptible, intermediate, or resistant, may hide an emerging resistance character in microorganisms with a small decrease in susceptibility that may still be classified as susceptible. In order to obtain reproducible and comparable results, all laboratories that participate in AMR surveillance programs should adhere to international standards. These standards include strict adherence to quality control QC and quality assurance QA procedures. QC refers to the operational techniques that are used to ensure accuracy and reproducibility of AST. QA includes but is not limited to monitoring, record keeping, evaluating, taking potential corrective actions if necessary, calibration and maintenance of equipment, proficiency testing, training, and QC. A QA program helps ensure that testing materials and processes provide consistent quality results. In addition, the following components should be determined and monitored. 1. Precision of the AST procedure. 2. Accuracy of the AST procedure. 3. Qualifications, competence, and proficiency of the laboratory personnel. And 4. Assessing and monitoring reagent and its performance before use. AST results may be used by health facilities in different ways. For example, AST results should be reported to the requesting clinician for patient management. AST results can be aggregated for development of antibiograms at the end of the year to guide empiric treatment of patients as the clinician awaits laboratory results or where microbiology laboratory services are not available. A combination of epidemiological and laboratory data collected over a stated period of time allows stratification of populations for ascertaining the type of infection, where and among what population the AMR infections are occurring. The extent of AMR infections can be assessed from epidemiological indicators such as incidence rates and prevalence rates. This slide outlines molecular methods for AMR detection. Molecular methods are of varying complexity and require different laboratory capacity and training. Many low and middle income countries do not have the laboratory infrastructure required to conduct molecular tests. However, isolates or specimens can be shipped to well established reference laboratories in country or outside the country that conduct molecular AMR testing. It is foreseen that whole genome sequencing will have a bigger role in the future of AMR surveillance globally. Based on the mechanism of action, four categories of tests are available: amplification tests, such as PCR and loop mediated isothermal amplification; hybridization tests, such as arrays, fluorescent in situ hybridization, and line probe assays; immunoassays, to detect AMR gene products by binding to specific antibodies, such as lateral flow immunoassays and nucleic acid lateral flow assays; sequencing tests, such as whole genome sequencing, nanopore metagenomics, and matrix assisted laser desorption ionization time of flight mass spectrometry.